بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد وعلى آله وصحبه وسلم أجمعين. I think we're going to start our second session this morning, and it's my pleasure to present Dr. Maulay Mizyani. Dr. Maulay Mizyani is the chairman of Department of Radiology at Cleveland Clinic in Abu Dhabi, which I hear that is under construction, and it should be ready maybe in 2 years. So prepare your CVs, guys. He's a consultant staff imaging at head thoracic imaging section at the Institute of Cleveland Clinic in Ohio, USA. He is a lecturer and author and researcher whose scientific works have been published in national and international scientific journals. Dr. Mizyani is going to enrich us about 3 topics in a very important subject, a subject that as usually creates some confusion to many practicing radiologists. First subject is pattern recognition in pulmonary CT, and the second subject will be high resolution CT of interstitial lung disease, and the last one will be the solitary pulmonary nodules diagnostic challenges. Dr. Mizyani, please.
Thank you very much for a nice and kind presentation. I guess I have to start by saying Bismillah ar-Rahman ar-Rahim, Assalamu alaikum wa rahmatullahi ta'ala wa barakatuh. Before I start, I want to take the opportunity to thank the organizer for inviting me, and especially Dr. Musleh al-Radadi. I came here to Saudi Arabia, especially to Medina, 10 years ago, and this is my second visit, and to me actually is a true pilgrimage in its own sense of the term, and it's really an honor to be here, and it's humbling to be in the holy city and having the opportunity to talk to you and to lecture. I have to say that also as a chest radiologist, you have to be very humble, because this is very basic, but it is something that we see on a daily basis. And I have to say that after 35 years of being a chest radiologist, I'm still learning every day, and it is very challenging to actually face the chest X-ray and face the complexity of chest CTs. So excuse me if I'm going to go back to some of the basics and talk to you a little bit about the basic anatomy as we try to understanding in order to be able to understand the pathology that affects the lung and the pulmonary tissue. So some of the things that I'm presenting today, I have presented in some of my past conferences, but I always think that it's important that you have to change some of the material, but the basic, and especially the basic anatomy, will always stay the same. So if we can switch onto the screens. And I have to apologize for the audience on my left because of the fact that the screen is a little bit blurry. So I think you're luckier if you look at this screen, especially if you're going to look at subtle findings. So if you look at the lung specimen and the lung tissue, it's basically a very fine supporting connective tissue with some vessels, veins and arteries, and some branches of lymphatics, and especially the connective supporting tissue. And most of it is air, so it is somewhat bland kind of tissue when there is really not much of a pattern to recognize. And when you look at the lung tissue on a CAT scan, the same thing, as you do see some few dots and some few lines, and you do see sometimes the fissures, but they basically just like branches coming out of a trunk and then spreading toward the periphery of the chest and then branching and becoming thinner. If you try to take a scan of the specimen itself, again, that's the same thing that you're going to recognize, this very vague blending of tissues that represent the supporting connective tissue, and then some of the vessels and some of the bronchi coming from the center of the chest, the highland, and branching out toward the periphery of the lung. But And this is basically, as you can see here, those branches depending on the section of the cut, whether you can see them as linear branches or you can see them as dots, depending whether they're cross-sectional or longitudinal branches. But as you can see, they do taper as they go toward the periphery. But it's not until you go to the very periphery of the lung that you're going to start to recognize something like this, which is basically some polyhedral structures that are square between 1.5 to 2.5 millimeter in 2.5 centimeters in diameter. And those represent really the core structure of the lung tissue, which is the secondary pulmonary lobule. And as we're going to evolve talking about the different patterns in the lung CT especially, you're going to see that most of what happens at the level of pathology, most of what happens in the lung will happen at the level of the secondary pulmonary lobule. And everything will be a reflection to what happened at the level of the secondary pulmonary lobule. So we're going to spend a few minutes just talking about the secondary pulmonary lobule. But just remember that the secondary pulmonary lobule are better recognized in a healthy normal lung, more toward the periphery where they're well arranged. But as you go toward the center of the lung, you have a lot of communication and a lot of disruption in the boundaries of the secondary pulmonary lobule. That way you don't recognize it as well. But if I look at the lung specimen, it's this framework of linear lines. As you can see, this patient has a little bit of anthracosis, from living in a city that has a lot of, smoke inhalation. But you can see this anthracosis is outlining the outline or the boundary of the secondary pulmonary lobule. And if I want to do a diagram, this is basically how the secondary pulmonary lobule structure looks like. So you have a conglomeration of 4 secondary pulmonary lobules. So these polyhedral structures, if I want to magnify that, and what you have as far as you have the supporting connective tissue that form the interlobular septa, but then you have the veins that are going to be at the periphery, and then you have the central arteriole and the central bronchiole that are going to be in the center of the secondary pulmonary lobule, and that's what they represent the central core. And you'll be able to, if you look for that very carefully in the lung tissue, especially on a CT, you'll be able to recognize those entities as separate units. So as I mentioned, they're polyhedral in shape from 1 to 2.5 centimeter in diameter, and they're supplied by bronchial and pulmonary artery branches. But also they're marginated by connective tissue that forms the septa, and within those septa you have basically the lymphatics and the veins running along those septa. And again, if you look at the periphery of the lung, you see these polyhedral structures, and then you have the central arteriole and bronchial within that. Then, of course, the secondary pulmonary lobule themselves represent a conglomeration of acini. The acinus, and you remember the acinus disease. This is something where you see that it's a disease that reflected to the size of the acinus is anywhere between 5 to 8 millimeters. And in very early disease, in very early space disease, as we're going to see, you'll be able to actually recognize the acini and say, okay, well, this is the configuration of the acinus. That means that this is alveolar disease or early alveolar disease or minimal alveolar disease. However, when you go beyond the acini, then the CAT scans, at least today's scanner, cannot resolve the detail of the terminal bronchioles. And that's something that I need to emphasize. So really the basic structure that you need to recognize is the secondary pulmonary lobule. And if you're lucky to identify what happens within the confine of the secondary pulmonary lobule, i.e. the acinus, then you'll be able to detect early or minimal disease. So again, just a cross-section of the secondary pulmonary lobule, the interlobular septa, and I keep re-emphasizing this because once now we understand the configuration and the anatomy of the lung tissue, it's much easier to understand what happens when you have pathology, especially early pathology, and then you'll be able to characterize interstitial lung disease versus alveolar disease, and then what type of interstitial lung disease if you know, again, your basic understanding of the anatomy. So again, if you look at the acinus, 5 to 8 millimeter in size, remember the secondary pulmonary lobule, 1 to 2.5 centimeter in size, and then you get into the terminal bronchioles, but then when you get at the level of the terminal bronchiole, now we're talking at the level of the microns. And then we don't have, in today's scanners, we don't have such a resolution to see at the sub-millimeter level. We can resolve with today's scanner, with the edge enhancement and so on, we can see up to 0.2 millimeter in size as far as fine structure. And we're lucky to see them in the lungs because of the fact that they outline by air, so it does have a very nice contrast. But when you get to the level of the terminal bronchiole and then, of course, of the respiratory bronchiole of branching order of 1 and 2 and 3, this is just too small to be seen. And the very end structure and the smaller structure that you see within the secondary pulmonary lobule, within the sinus, is going to be the alveolar duct. And that's where the actual gas exchange then happen. But as you can see, when pathology involves those different structures, obviously the function of the lung will be affected. So if I show you an actual case of a lung tissue on a live patient, you can see that now in the periphery, and as you can see here, the secondary pulmonary lobule are going to be outlined if you look closer for them. And again, there's polyhedral structures. You can see, if you look very closely, you see the central core, which is the central arterial and the central bronchial. And you have a second unit here next to it. But as you go toward the center of the lung, there is a lot of disruption in between the interlobular septa. So they're not well organized, and you don't recognize them as a single entity. You have a lot of communication. The pore of Kohns and the canals of Lambert are the ones that they describe as the things that communicate between the different single structures of secondary pulmonary lobule. So you have the lobular septa or the interlobular septa, and it's very important because a lot of things happen at the level of the interlobular septum. That's the manifestation of interstitial lung disease, as we can recognize later. But if you know what lives within the interlobular septa, then you know what's the cause of the interstitial lung disease. In the interlobular septum, you have the supporting connective tissue, and you have veins, and you have lymphatics. So everything that involves those different structures can be manifested as interstitial lung disease. Now, when you are outside of the interlobular septa, when you're within the confine of the second pulmonary lobule, then we're talking about airspace disease. You're at the level of the alveolar sacs, you're at the level of the acinus. Again, if you can, then you see the arterioles, and then the bronchioles are just too small at this stage to be seen. But then you have the venous branches, especially at the bifurcation of the interlobular septa. And then, but if you can follow that as you move, then you can see, you can follow those different structures. So here you are as you go into the pulmonary artery branches. And then the same thing with the venous branches, you can follow them. But I have to say, if you don't follow them, it's hard to characterize what kind of vessel it is. Is it an artery or it is a vein? Until you follow slice by slice, and you can tell this is branching to a vein, going to the pulmonary vein, and this is branching to the pulmonary artery and going to the main pulmonary artery. So if you look at the CT patterns, we talked a little bit about the underlying anatomy of the lung tissue. There are four major different categories that can happen within the lungs. You can see it as a decreased lung opacity, so we're talking mainly about air-filled cystic disease, and they can be diffuse or they can be local. We're going to talk mainly about diffuse cystic lung disease. We can look at increased lung opacity, and that's usually talking about airspace disease in general. And then we can see different stages of increased lung opacities. And then you have nodular opacities. Those really do not respect any boundaries within the secondary pulmonary lobules. And talking about nodular disease, talking mainly about lung cancer, so it will not respect any boundaries and it will destroy things around. But nodular opacities can be seen as single pulmonary nodules, and we're going to have a whole discussion on that toward the end of my talks. But you can have also multiple nodular opacities, but their distribution is the one that's going to help us determine what may be the cause of the nodular opacities. And then you have the reticular or linear opacities, and those are basically reflection of interstitial lung disease, as I showed you before, is the framework of interlobular septa outlining secondary pulmonary lobules. So if you look at a single secondary pulmonary lobule and you look at the densities that you see on the CAT scan, I think if you want to put a cursor and looking at the Hounsfield unit, so the normal lung tissue, because it's mainly filled with air with this minimal supporting connective tissue, it's around minus 850. And then below that, you're talking about airspace or decreased opacity of the lung. And then we're talking, a good example would be pulmonary emphysema, and we're going to see some examples of that. And then you have, as you go to thickening of the interlobular septa, then you may see this framework of thickening of the outline of the secondary pulmonary lobule, but also intralobular septa. And then you have increased opacity, so in reflection of in contrast with interstitial lung disease, you see this increased opacity within the confine of the secondary pulmonary lobule and the acini. And then, of course, with different involvement or different concentration of disease within the alveoli, then you may see different degree of involvement within airspace disease. So a few examples of decreased opacity. A good example is centrilobular pulmonary emphysema. And again, we say centrilobular because it does happen within the center of the pulmonary lobe. It has tendency also to respect the, while it expands the secondary pulmonary lobe, it to respect its size, but more importantly, to respect the orientation and the position of the core structure, which is the central arteriole and the central bronchiole. So I'm going to show you some examples of that. And this is a good example showing the areas of decreased opacity, and here's a secondary pulmonary lobule here, but you can see that the central arteriole is still within the confine of the secondary pulmonary lobule. Here's another area, I don't know how well it's reflecting there, but here's another area of decreased opacity representing central lobular pulmonary emphysema. And of course, when you have advanced disease, you have multiple areas of decreased opacity. One thing that you want to contrast this with true cystic disease is the fact that there is no surrounding wall outlining these areas of decreased opacity, in contrast with true cystic disease where there is a wall. So in patients with central lobular pulmonary emphysema, you have destruction and expansion of the secondary pulmonary lobule. Another form well, let me just show you some few examples that have pathology proven cases of pulmonary emphysema. Again, this is a nice example of a specimen showing that the areas of lucencies that represent areas of destruction within the secondary pulmonary lobule. This is a patient with moderate emphysema, and the point I'm showing this is because we have tendency to recognize pulmonary emphysema on a chest X-ray by hyperexpansion and flattening of the diaphragm. That's not seen until you have advanced pulmonary emphysema, and obviously when the emphysema is set up, you don't have any way to help the patient because that's not a regressive disease. But it is in the cases of minimal emphysema for which you can ask the patient to stop smoking, because then you may make an impact. But is this on the CAT scan, again, showing different degree of pulmonary emphysema, these areas of destruction within the confine of the secondary pulmonary lobule here with no definable wall. But it's not until they coalesce together to form this Bull's disease then we can see this septation. But here there is no tissue here. This is totally devoid of any lung tissue. So this is coalescence of areas of central lobular pulmonary emphysema, and typically seen in the APCs, and this is the typical ones related to cigarette smoking. In advanced, again, pulmonary emphysema, you see these areas of coalescence of destroyed lung into Bull's disease. But it's in the cases of minimal emphysema that you can, as a radiologist, make an impact and helping the patient to stop smoking. I have to say that in a smoking cessation program, I think the best probably motivator or the best deterrent is showing the patients their actual lungs, and that's probably has had more impact on having the patient basically realize that there is a damage to their lungs, and that's where they stop. In my own experience, this when you show these areas of pulmonary emphysema to the patient, that had more impact than actually going through those other programs. And this is when we start doing this lung screening, especially in the patients that are heavy smokers. Again, this is an example of a very subtle but early pulmonary emphysema with these areas of decreased opacity. Just very quickly, the pan-acinar emphysema is a little bit different in the sense that it's not just involving the center of the secondary pulmonary lobule, but diffusely involving the lungs. And then you have hyperexpansion. It's much harder to detect when there is diffuse involvement, but as you can see, there's much less decreased number of pulmonary vessels that are seen, and the supporting connective tissue is not that well seen. The difference also between central lobular emphysema and pan-acinar pulmonary emphysema is the fact that this is something that involves the entire lung, and especially also the lower lungs in contrast to the upper lungs with central lobular emphysema. So the good example of pan-acinar pulmonary emphysema is a patient with the alpha-1 antitrypsin deficiency. So this is the panlobular emphysema. Again, you can see that there is much more involvement to the lung basis in contrast to the central lobular pulmonary emphysema. Paraseptal pulmonary emphysema is just a different form of emphysema. It's a different form of central lobular emphysema, but it has this peripheral distribution that is somewhat unique, but it is seen mainly in the patients that are heavy smokers. But one thing that you see in those patients that have peripheral disease and Bull's disease is the fact that they're very close to the pleura. Those things have tendency to rupture into the pleura, and you end up with spontaneous pneumothoraces, as you can see in this patient. And this becomes an emergency because the patient has already underlying pulmonary emphysema, and then they can put them over the edge. So those patients definitely need a chest tube to treat that pulmonary emphysema. Now, I want to contrast just two, but a relatively rare disease that have diffuse cystic disease is the one that have actually a wall surrounding these areas of increased opacity. And the two good examples are patients with lymphangioliomyomatosis. As you can see here, this can be mistaken by a patient by diffuse central lobe pulmonary emphysema. But the difference here is the fact that in all those areas that you see that have an area of increased opacity, there's a relatively well-defined wall here. And also the size of the cysts are somewhat random and uniform, anywhere between a few millimeters to up to 2 centimeters in size. So this is a rare disease, but it is a specific disease that does give you diffuse cystic changes that can mimic central lobular pulmonary emphysema. The other one is this entity. Can somebody tell me what this entity is? HC. Right? Histocytosis X. So the thing that why we recognize this is not only because they are definable wall, but it have this bizarre shape and they're not uniform size cyst. And so this is also patients that are heavy smokers, but it is also a separate and easily diagnosed condition. And this is another patient with histocytosis X. Again, this is not pulmonary emphysema. You can see that all those areas of destruction have a very well-defined wall. And also not to mistake this for a patient with honeycombing and patient with end-stage lung disease due to pulmonary fibrosis. That's also different. In those conditions, the walls are much thicker, the size of the cysts are smaller, they're more peripheral, and more importantly, you have loss of volume and you have distortion of the architecture of the lung parenchyma in contrast to those conditions. Now, this is a somewhat unique and easily recognizable disease of the lungs that have also diffuse cystic disease. But the difference between this is the distribution. Look at the distribution of these cystic changes. They're more in the medial portion of the lungs. So this is what? Anybody? That's right, bronchiectasis. So this is cystic bronchiectasis. And what happens is sometimes when the bronchi becomes dilated, especially in a cystic manner, they can mimic diffuse cystic disease. But there is another clue here, is the fact that there is tracheobronchomegaly, but mainly here bronchomegaly. So this is actually Mooney-Kuhn disease, where patients with tracheobronchomegaly and they have disruption and congenital absence of the cartilage in the first and second orders of the bronchi, and that's why you have this cystic dilatation, and most of them are going to be congenital conditions. And this is just to take me to the no other pattern recognition is the fact that we can easily with the CT recognize bronchiectasis. And we used to do this old and somewhat traumatic procedure called bronchography to make the diagnosis of bronchiectasis. But now we can recognize it in CT just by the fact that we can trace the course of the bronchus, but more importantly, we can see it's dilated in comparison to the accompanying artery. So if the bronchus next to the artery is the same size or bigger than the accompanying artery, that's a definition of bronchiectasis. And this is what I was alluding to. This is what we used to. And I think I did one or two in my career, early in my career as a resident, almost 35 years ago. But very quickly, CT has replaced it. But this is what we call the bronchus sign, right? So this is the accompanying, this is the bronchus, and this is the accompanying artery. This has the signet ring sign. And again, this is your diagnosis or your easy diagnosis of bronchiectasis, an area of, again, decreased opacity, signet ring sign. Here's another patient with bronchiectasis. Again, you can see the medial distribution of the bronchus and the dilatation of the bronchi. Here's another case of Mooney-Kuhn, again, showing the cystic bronchiectasis, but also the dilatation of the trachea and the bronchi. Nodular disease, I'm not going to dwell too much on this because I'm going to talk more extensively in my my next talk. But basically, on the nodular disease, the main thing that we have to recognize is that if this nodule is of a benign nature or if it's a malignant nature. And that's the biggest dilemma that we have as a radiologist. So I'm going to extend more on that. But one thing that is important as far as pattern recognition, when the lesion is very small, one thing is you have to do some follow-up. So try to get the prior studies, whether it's chest X-ray or a CAT scan, because that's how you can see that the lesion is evolving or is stable. And that's how you can determine if the lesion has a potential malignant nature or benign nature. This is a patient in 2008. You can see this tiny nodule in the posterior aspect of the left apex here in 2008. However, when the person that compared it to 2007 thought that actually the lesion was bigger in 2007 and said, okay, well, this is something that is most likely benign, and didn't ask for more follow-up. However, that person did not take the exercise of looking way back in 2005, and if that was available, you can see actually the lesion was very much smaller or totally absent. And of course, that patient was lost to follow-up, came back now 3 years later, and then this is a cancer with already advanced metastatic disease. So the point is to stress that there is a difficulty in trying to determine the nature of the lesion when it's very small. Those are indeterminate nodules, but we do have the ability to look at the growth and to look at prior studies, try to determine if the lesion has a potential malignancy or not. And again, I will elaborate that more. We can look at the content of the nodule, of course, their characterization as far as if there is calcium and what type of calcium and distribution of calcium. I'm going to talk a little more about that later, but again, calcium usually means benign disease, but there's certain areas where calcium can also mean malignancy, and so not all calcific lesions are benign in nature. The contour of the lesion obviously is very important. If it's spiculated or lobulated, this is most likely to be a malignant lesion, but of course, we're still left with those indeterminate nodules for which there is no calcium and there is no contour characteristic to tell you it's benign or not. I just want to emphasize that you can characterize the nodule by doing targeting scanning. That allows you to see more or resolve more the nature of the lesion, its contour and its content. As you can see in this patient, this lesion we can tell now that it's spiculated, it has central cavitation, most likely to be a cancer. Again, having thin cuts will help you. This is a patient with a small nodule, hard to characterize, but repeating the study and doing thin slice nodules, you can see that the patient does have central calcification, characteristic of benign granuloma. Patients with the nodule that has an accompanying artery is highly suggestive of a pulmonary AV malformation, even though the lesion is small. And it's not until you have large lesions with true enhancement that you can see that this is an actual diagnosis of pulmonary AVM. And I mentioned earlier the bronchosign, that's also another characteristic that help you into determining if the lesion is amenable to biopsy or not. Sometimes characterization of the contour of the nodule and the surrounding tissue can be very important. And one thing that we described many years ago is the halo sign, and the halo sign is this area of haze around the nodule, whether it's a single nodule or multiple nodules. And there are multiple causes. Originally, we would describe this as mainly being part of invasive aspergillosis or patients with early infection and coagulative necrosis and hemorrhage surrounding the lesion that is highly suggestive of aspergillosis in the immunocompromised patient. But we know that there are other causes of halo signs. So you can tell that you can have either areas of surrounding hemorrhage, or you can have cellular infiltrate in the cases of infection. So angioinvasive aspergillosis, but also neoplastic disease, especially metastatic disease from hypervascular tumors such as renal cell carcinoma, Kaposi sarcoma will give you this halo sign if you catch it early. Wegener's granulomatosis being a vasculitis, you get these granulomas with some also a hemorrhage around the lesion. But also something like bronchoalveolar carcinoma and metastatic carcinoma of adenoCA origin can give you that. So the point is that there are multiple causes of halo sign. But in the right host, especially in the immunocompromised host, you have to think about aspergillosis, especially invasive aspergillosis. And this is an early example of halo sign in patient with invasive aspergillosis. The patient passed away, and this is the specimen showing those areas of nodular densities, but then these areas of hemorrhage forming this early halo sign. And again, just showing the nodule on a specimen. and then the hemorrhage around it, but also showing the invasive nature of the aspergillosis invading and rupturing the vessel. I think distribution of nodules, especially multiple nodules, is somewhat characteristic and helps you to try to suggest what may be the cause of the disease. So the overall distribution of the nodule help in differentiating, especially perilymphatic from random distribution. And the one that will lead to recognize this perilymphatic disease. In the United States, especially in our practice, we see a lot of sarcoidosis, and this is something that is easily recognizable if you follow the pattern of the distribution of the nodules. I'm not sure sarcoidosis is very common here, but the other diseases that follow this perilymphatic distribution are lymphoma, Kaposi sarcoma, and some other entities. But sarcoidosis typically is the one that has this perilymphatic distribution. So you have the perilymphatic nodules. Knowing where the lymphatic live, they live mainly in the periphery, but also along the axial interstitium. Then you have the concentration and distribution of those nodules in those areas. The random nodules basically nodules that don't follow any specific pattern. But also there is another distribution of nodules that we need to recognize are the central lobular nodules. And those actually are manifestation of early airspace disease. So the twin bud appearance of central lobular nodules. And again, in relationship to the secondary pulmonary lobule, those are the different distribution of the nodules and where they reside in relationship to the different component of the normal anatomy of the lung. So an example of, again, perilymphatic distribution, again, this distribution along the axial bronchovascular bundles, but also along the periphery in a subpleural space. And this is something that we see typically in a patient with sarcoidosis. So you can see this, again, this perilymphatic distribution along the bronchovascular bundles. Here's another patient with sarcoidosis, again, with perilymphatic distribution, but you look at the concentration also in the subpleural space in the periphery of the lungs. So this is highly suggestive of patient with sarcoidosis with the involvement of the lung parenchyma. The random nodules, they basically don't have any specific distribution. You may see that in metastasis. You may see that in patient with silicosis, patient with histiocytosine X. So things that don't have any particular distribution. And again, a random distribution. And then this is a patient with silicosis showing that there are random nodules scattered throughout both lungs with no particular distribution. I have to say, though, that sarcoidosis can give you everything and can give you also random nodules. Patient with extensive adenopathy and random nodules. And then you have the twin bud appearance or the central lobular distribution, and then you can see they have this basically these small fruits at the end of the or the small buds at the end of those branches. And this is an early manifestation of airspace disease and acinar disease. So central lobular nodule. This is also highly recognizable. And if you look closer here, you can see that those distribution here, especially here in the bottom portion of the right lower lobe, you can see how they follow this bronchi that are filled with material, and then you have these basically fruits or buds at the end of those branches, and this is what we call it the twin bud appearance. And here are two examples of twin bud appearance, but this is two patients that have some different concentration and manifestation of bronchoalveolar carcinoma. But again, bronchoalveolar carcinoma being a pure alveolar disease will manifest in early stages at this twin bud appearance, central lobular nodule. And then as you have conglomeration of disease, obviously then you get into more lobar and segmental and lobar consolidation. So this patient with bronchoalveolar carcinoma. So this is to bring me to the topic of airspace disease. This is much easier to recognize because it is within the confine of the secondary pulmonary nodule. And then you will start at the level of the air sac, then spread into the level of the acini, and then secondary pulmonary lobule. And then from there you have progression of disease into segmental and lobar disease and diffuse consolidation. So again, within the confine of the secondary pulmonary lobule. This is a good example of just bacterial pneumonia, but showing in the early and minimal disease, you have this very fluffy, small, round opacity with pore margin. So those are the level of the acinus. So this is the size of an acinus, 5 to 8 millimeter. Here's another one here. You look here closer, here you have some twin bud appearance. And then, however, when you have more conglomeration of this disease, then you get into this consolidation, air bronchogram, and then segmental and lobar disease. And if you know what lives within, or what can live within the airspace, then you can tell what may be the cause. So in the airspace, what can you have? You can have fluid, which is edema. You can have pus, which is pneumonia, as in this case here. You may have hemorrhage, and you may have alveolar disease due to either rare things like alveolar proteinosis, lymphoma, or bronchoalveolar carcinoma. So there are only 5 things that can happen there. Then, as far as to recognize it, they may all have the same appearance, but they may have different distribution. They may have different evolution over time. We know edema can fluctuate in a matter of hours. Pneumonia won't do that. It won't fluctuate in a matter of hours. You fluctuate in a matter of days, and maybe weeks. Hemorrhage, maybe in a matter of a couple of days. So again, you know what may be the cause. You limit your differential diagnosis to those 3 or 4 causes. And then after that, we're looking at the evolution, the patient's condition, the clinical condition. You can, as a radiologist, actually come up with a very precise diagnosis. This is an example. We don't do a CAT scan for pulmonary edema, but this is an example showing the different degree of pulmonary edema. You see the distribution, patient bedridden, so the edema is going to be in the dependent portion. You have this fluffy appearance of the secondary pulmonary lobule filled with airspace, but also you have this. So what is this here? You remember the secondary pulmonary lobule? This is it. Why is it outlined here? Because the interlobular septum is thickened. Why is it thickened? Because we know that fluid can go into the interstitium. And this is a nice example of a combination of both interstitial lung disease and airspace disease. And so when you have that, when you have airspace disease and interstitial lung disease, you may get to this crazy paving pattern when the distribution has this geographic presentation. And there are not that many things that can give you this combination of airspace disease and this framework of interstitial lung disease. A good example of this crazy paving pattern is alveolar proteinosis, as you all know. But then it shows that in those patients with alveolar proteinosis, there's a reaction of the interstitium, and that's why the interstitium is thickened. But look at the distribution here. So there's some areas that are totally spared of the disease and some areas that are not spared of disease. And not that many things that can give you this appearance. So I'm going to go to the next. I'm going to just take a couple of minutes just to go to the next presentation on interstitial lung disease, which is really a continuation of what we're talking about, pattern recognition. Can we move to the screen? So if I use again the model of the secondary pulmonary lobule, and if I look at how I recognize interstitial lung disease, I look at the anatomy of the secondary pulmonary lobule, and I look at the outlining supporting connective tissue. And then you can see here what I have here depicted is the fact that the interlobular septa are much thicker than what the normal appearance of an interlobular septum, which is going to be at 1 millimeter or less. This is a diagram that I'm getting from a work that was done over 30 years ago when we started playing with the interstitial lung disease. And if you look at the different signs in this diagram, I have all the signs that are depicted on how to recognize interstitial lung disease, especially early interstitial lung disease. The first one is this thickened and irregular interfaces. So if you remember that the interstitium also outlined the visceral pleura, or just below the visceral pleura, but also it outlines the axial interstitium along the vessels and along the bronchi. So in early and minimal interstitial lung disease, you're going to start to see this irregular interface between the pleura and the parenchyma. And instead of having this smooth appearance, you have this irregular appearance. The same thing here, you have this sawtooth appearance along the bronchovascular bundle. And that's especially the patient that have abnormal pulmonary function tests and normal chest X-ray. The CAT scan may depict those findings that can be a sign of fixed and early interstitial lung disease. Then you have the linear abnormalities, and there are different degrees of linear abnormalities. The ones that are easily recognized are the interlobular interstitial thickening. And this is the one that we talked earlier about, the thickening of the interlobular septa outlining secondary pulmonary lobule. But then you may have different degree of intralobular septal thickening depending on the severity of the disease and the extent of the disease. So you have this framework of linear and reticular lines within the confines of the secondary pulmonary lobule. One thing that is hard to recognize or hard to determine is the ground glass opacities. We know that both early airspace disease and early interstitial lung disease can give you ground glass opacities. But in the patients for which there is only reaction of the wall of the alveolar sacs and the different branching order of the respiratory bronchioles, it may be depicted as a as a ground glass opacity, but true manifestation of interstitial lung disease rather than airspace disease. And I mentioned lung remodeling and destruction just as a manifestation of one cause of interstitial lung disease, which is pulmonary fibrosis. Because when you look at the definition of interstitial lung disease based on the chest X-ray, that's one thing that is recognized is the lung remodeling and destruction and the honeycombing. So in early fibrosis, this is what I was talking about, these pleuroparenchymal interfaces. You can see this very fine, irregular, linear lines at the periphery of the lungs, but you can see, even though the fissure is centered in the center of this lung section, but also it's part of the periphery of the lung. So you see this irregular appearance also of the pleuroparenchymal interface, also along the fissure, but not also along the chest wall. So this is a patient with proven pulmonomyositis, but did definitely have abnormal pulmonary function tests, and then those irregular lines. And then another patient with scleroderma that does have a more advanced disease of abnormal and irregular pleuroparenchymal interfaces. So you want to make sure that also those are fixed findings. So if there is any question, you can move the patient to the other position to make sure this is not just dependent edema and atelectasis in the dependent portion of the lung. This is obviously also easily recognized that it is scleroderma because of the fact that you have dilatation of the esophagus. And so what you need to do, like I mentioned, you move the patient from the supine to the prone position to make sure that this is actually, it's a fixed findings and it's due to actually fibrosis and not a dependent atelectasis and pulmonary edema. Another lines that, or another findings that we described in the periphery is the subpleural lines, and it was initially described mainly in a patient with prior asbestos exposure and early changes of asbestosis, but we've seen later that it can be seen in other entities. But in the right setting, it is highly suggestive of early asbestosis, so you don't have to see just the peripheral lines, but you have to see this fixed also, this fixed subpleural lines that is somewhat separate from the actual very periphery of the lung, but it does parallel the chest wall, and it's a fixed, again, phenomenon. It's not something that's going to be resolved when you change the patient's position. So again, dependent atelectasis can sometimes mimic this irregular pleuroparenchymal interface. As you can see in a normal patient, you see that this is going away. So the one that we easily recognize is those interlobular septic thickening as part of the linear abnormalities that we can easily recognize. And again, look at the contrast between this lung to the other lung. And you can see the normal appearance of the branching vessels and the bronchi. But here on the top of that, you have these reticular lines that actually form the interlobular septa outlining individual secondary pulmonary lobule. And you can see the central arterial and bronchial in the center. But here's one unit here. Here's another unit here, another unit, and another unit. See also how well they are arranged in the periphery. And a lot of people think actually the lung is divided into a medullary and cortical portion, just like in a kidney, where the cortical portion, the secondary pulmonary lobules, are very well arranged and organized together with outline all the way around. And as you go toward the center of the lung, then you have disruption of those secondary pulmonary lobule outline. That case was a rare case of lymphangiectasis, congenital lymphangiectasis. But again, if you know that the lymphatics run into the interlobular septa, then you can determine that may be the cause of that interlobular septal thickening. And this is actually the patient's chest X-ray, which is not very, very helpful. But then you look at the pathology, you have this dilatation of these large lymphatics within the interlobular septa. So again, interlobular septal thickening manifested as the thickened interlobular septa outlining secondary pulmonary lobule, and also you know that the lymphatics do run within the interlobular septa. So lymphatic disease, whether it's lymphangiectasia or lymphangitic spread of tumor, can manifest as this thickened interlobular septal. So again, another patient with interstitial thickening due to dilated lymphatics, and then you can see that they do outline secondary pulmonary lobule. And again, the same thing where you can see that those are fixed phenomenon of thickened interlobular septa in this patient with lymphangiectasis. We don't typically scan a patient for this entity, but just remember that also other things can happen within interlobular septa. Again, you see this framework of thickened interlobular septa, secondary pulmonary lobule, central arteriole. Now you can easily recognize them. But here, this is much not as pronounced and smoother. This is a patient with just pulmonary edema and early interstitial edema. Again, interstitial edema, you may have fluid going into the veins, but also going within the supporting connective tissue. So the very early changes of interstitial edema will manifest as this thickened interlobular septal thickening. Also, interstitial edema early can present as this, what we see on the chest X-ray as peribronchial cuffing, knowing that also there is interstitium surrounding the bronchi and surrounding the vessels. So peribronchial vascular interstitial thickening can be due to multiple causes, but typically in early edema, that's what you will recognize, especially on chest X-ray, as this peribronchial cuffing. And this is what I talk about on the peribronchial cuffing. So you can see here that there is this pseudo thickening of the wall of the bronchus. Actually, it's not the wall itself, but it's the interstitium surrounding the wall that is filled with fluid. It may be seen also, of course, in other causes as inflammation and other causes that can affect the supporting connective tissue. But these happen to be just simple cases of pulmonary edema. But I wanted to illustrate this just to show you this is the equivalent of peribronchial cuffing that you see on the chest X-ray. So edema is one of the causes of linear lines and interstitial thickening. So we talked about lymphangiectasia, and then there's this case here. Now look at the difference between this one and that one. This one in the bottom shows that there is thickening of the interlobular septa, but look at this nodular characteristic of this nodular septal thickening. And not that many things that can give you nodular septal thickening. And you can see again here, and you can see it here. So in the right setting, this is a patient with lymphangitic carcinomatosis. So again, knowing that the lymphatics live there, and knowing that when you have deposit of tumor, they can be nodular, it gives you this typical appearance we call the beaded appearance of the thickening of the interlobular septal thickening. But in order to recognize lymphangitic spread of tumor, you have to know that there is the pathophysiology on why do you have how do you get lymphangitic spread of tumor. So you have to have one of two conditions to be able to make that diagnosis. So you see the thickened interlobular septa, you see it's beaded. Now you may or may not know that the patient has a pre-existing cancer. But then what you need to be looking for is for two things. One is to see already the presence of hematogenous spread. Because what happened is that there are already hematogenous metastases, and then the tumor is picked up by the lymphatics, and then it goes into the antegrade fashion. You know, the lymphatics go from the periphery to the center of the lung toward the hilum. So what you have then, you have antegrade, if you want, engorgement of the lymphatic by tumor deposit. The other things that if you don't have hematogen spread, then look for retrograde invasion of the lymphatic by tumor by having central hilar disease, lymph nodes filled with tumor, and then you have a retrograde filling of the lymphatics by direct invasion from the lymph nodes into the interstitium, and then you have retrograde. So need to look for those two things, and most of the time you'll be able to find one of those two entities in order to make that diagnosis. This is a patient with germ cell tumor with involvement of the lymphatics in the hilum. Poor patient didn't make it, but again, just to illustrate this irregular beaded appearance of the thickened interlobular septa in a patient with lymphangitic spread of carcinomatosis. And again, this is the same specimen showing the lymphatics filled with tumor here along the interlobular septa. But again, a lot of tumor deposits, especially at the level of the valves. As you know, there are lymphatics within there are valves within the lymphatics. Tumors sometimes also can directly invade the interstitium, not through the lymphatics, not through the vein, but directly through the connective tissue. This is a patient of having mesothelioma, malignant mesothelioma, had the totally opacified left hemithorax to an advanced mesothelioma, but then you look at the specimen on the right side, you can see that there is this reticulonodular appearance, and it's not until you look at the specimen, you can see that there is this white matter or this white deposit of tumor along the visceral pleura, but it's not until you look at the cross-section that you realize that there is nothing within the confine of the secondary pulmonary lobule. But however, in contrast, there is thickening of the interlobular septa, and this is all tumor deposit through the connective tissue and went through the peripheral interstitium into the interlobular septa. And then remember that obviously below the visceral pleura, you have the supporting connective tissue, and tumor can evolve from the pleura into the supporting connective tissue, and it can extend into the connecting interlobular septa. And that's what we have here, the example of tumor below the visceral pleura. This is all tumor due to mesothelioma, but you see how it goes into the interlobular septa. It basically just invaginate through the peripheral interstitium. Ground glass opacity, as I mentioned before, this is somewhat more difficult to make because it is going to be not in the outline of the interlobular septa, but within the confine of the interlobular septa. But because we cannot resolve very fine intralobular septal collagen supporting connective tissue, all we see is this ground glass appearance. And as you know, if you know the underlying entity, you will maybe suspect what may be the cause of that. So the causes of interstitial lung disease due to inflammation in early stages will manifest with the ground glass opacities that can mimic airspace disease. Most of the time, you're not going to see an air bronchogram in those patients, but that still does not exclude the fact that you may mistake that for airspace disease. So there is actually advanced ground glass opacity. It's not as dense as typically you see in airspace disease. You may see some few air bronchogram, and it has most of the time this geographic distribution. So this is a patient with the lupus pneumonitis and early changes of ground glass inflammation. Just remember that also in lupus pneumonitis, you may get infection, you may get hemorrhage that can mimic this appearance. Distribution, but more importantly, evolution of the disease will help you differentiate between those different entities. And of course, the clinical condition and the fever and so on. Vasculitis also, especially in patients with Wegener's granulomatosis, can give you these ground glass opacities that does have this unusual distribution. But things like extrinsic allergic alveolitis can give you this diffuse distribution. And again, with the right setting, then you will be able to make that diagnosis. But look how diffuse the disease, even though it's not very dense, it's minimal. You don't see that many air bronchogram. So this is highly suggestive of diffuse airspace disease. Another areas for interstitial lung disease give you ground glass opacities in a patient with pulmonary fibrosis. We can recognize easily pulmonary fibrosis when you have thickening of the interlobular septa. We can recognize easily pulmonary fibrosis when you see honeycombing. What's not very well appreciated is this diffuse increased opacity of the lung parenchyma overall, meaning also, again, we have a very fine interstitial lung disease that's below the resolution of our scanner's capability. But what you see here is this remodeling of the architecture of the lung tissue and pulling and retracting of the vessels and the hyla. Of course, here in this patient, you see some honeycombing and you see some distortion. But also, you need to appreciate this diffuse increased ground glass opacity due to diffuse pulmonary fibrosis. Now, in the right setting, you will have you have to be able to differentiate this at the cause of, is this IPF, idiopathic pulmonary fibrosis, and meaning UIP, usually interstitial pneumonitis, or is it non-specific interstitial pneumonitis? In non-specific interstitial pneumonitis, you may have this cellular phase that actually does have these ground glass opacities that are manifestation of inflammation. Those can be treatable. But when you have advanced fibrosis, they can give you also this appearance that is not treatable. And probably what we need to do next is to talk a little bit about the different entities of pulmonary fibrosis. So before I get that, just the honeycombing we'll talk a little bit about intralobular septal thickening, so different degrees of thickening within the confine of intralobular septal thickening, and the good example is idiopathic pulmonary fibrosis, for which within the confine of the secondary pulmonary lobule, you have this framework of multiple linear lines, and of course you may have some underlying honeycombing. And honeycombing is just an end-stage manifestation of pulmonary fibrosis. One thing that you need to recognize is the fact that when you see those cystic spaces, they have to be surrounded by this white line all the way around those cystic spaces. And so, again, to contrast early interstitial lung diseases due to pulmonary fibrosis, the peripheral distribution, as I mentioned, very early, and then the advanced disease when you can see in the bottom there where you have honeycombing and cicatricial bronchiectasis. And not to mimic also pulmonary fibrosis and honeycombing from a patient with paraseptal pulmonary emphysema. So this is probably going to be the right time to go to the somewhat hard topic of diffuse interstitial lung disease and the pneumonias that or have been recently classified, to try to get an understanding about the different causes of those idiopathic pneumonias. So the classification of idiopathic interstitial pneumonias, way back in the 60s, Libo came with the classification. I'm still very confused about how to recognize it, but it's not until recently that we try to make sense of those different pneumonias. So with the new ATS, few years ago, we have basically recognized 7 of them, but the most important one is probably the number 1 and 2, which is the idiopathic pulmonary fibrosis, or IPF, which is pathologically defined as usual, or UIP, usual interstitial pneumonia. You have the non-specific interstitial pneumonias, as the term mentioned, they're non-specific. You have the lymphoid interstitial pneumonias, LIP, which are rarely seen, can be also described in the pediatric patients, in the HIV patient. The RBILD, the respiratory bronchial associated interstitial lung disease, that actually easily recognized by a radiologist, but you have to have the right condition of a patient being a heavy smoker. The same thing with the DIP, which is also related to cigarette smoking. And then there is the one that we used to call BOOP, bronchiolitis obliterans pneumonia, which is now called COP, cryptogenic organizing pneumonia, and especially if it has a specific patterns that we can recognize. And rarely the acute interstitial pneumonia, what they used to call the Hammond-Rich syndrome, which is still some people debate whether really it exists or not, but it's a fulminant progression of interstitial lung disease for which there is really no cause, but there is injury to the lung, and the patient may develop very quickly, will develop pulmonary fibrosis. And we need to recognize that the first 4 are chronic changes, are chronic diseases or chronic conditions. The subacute conditions are the DIP and the COP, and then the acute conditions are the last one, the acute interstitial pneumonia. I don't know how much time I have. I think I have to go very quickly because this is more has to do with some of the clinical findings and some of the pathology findings. But just remember that it is a diagnosis of occlusion when you get IPF. It does have poor prognosis, and usually it develops at the age of around 60, and the patient survival is around 5 years. However, it does, in order to make the diagnosis of IPF, you have to find some few clues, and the most important clues that you have to find is the fact that there is honeycombing, and obviously there is going to be, because of honeycombing, there's going to be cicatricial bronchiectasis. And typically it's in the periphery of the lungs, and as you can see, the bottom of the lungs is part of the periphery, so you see these areas of honeycombing, you see the cicatricial bronchiectasis, and you see the distortion of the lung parenchyma. Just remember that IPF by itself is all within the UIP, but there are other things that can give you a pattern of UIP. So toxic drugs can give you that, asbestos exposure, so asbestosis can give you a pattern of UIP, collagen vascular disease also can give you that. Again, like I said, usually typically after the age of 50, and it does have poor prognosis, 2.5 to 3.5 median survival. And really treatment right now, if the patient can qualify it, is lung transplant. And they may benefit from either single lung transplant or double lung transplant. But again, here's another example of UIP or IPF showing this peripheral distribution of the pulmonary fibrosis and the honeycombing. And again, peripheral distribution, and I'm not going to get too much into the pathology. So the usual interstitial pneumonitis pattern, I'm not going to go into the pathology. I want to go very quickly to the non-specific interstitial pneumonia. We need to recognize there are 2 forms of non-specific interstitial pneumonia. There is a cellular form and there is a fibrotic form. And the fibrotic form can be hard to separate from IPF or from early IPF. But obviously the progression is going to be different. But very quickly, I'm just going to show you some example of NSIP, proven NSIP. So this is quite different than the cases I showed you of UIP. You have these ground-glass opacities. They talk about this relatively, but also in a fibrotic form, you have this peripheral distribution that can mimic early pulmonary fibrosis due to IPF and UIP. But they talk about this relative sparing of the periphery in the subpleural space, as you can see in this patient here. And I didn't find that very, very helpful, but if you see it, that's something for you to recognize. but you can see the cicatricial bronchiectasis, and there is also a lack of honeycombing in most of the patients with NSIP. Even in the patients with fibrotic NSIP, there is an absence of honeycombing, and that's one way to try to separate. And obviously, the prognoses are different, the treatment is different, they can benefit from steroid treatment. But here's a cellular NSIP, you can see these ground glass changes, and you can see them in the periphery. But then look at this here, especially in the dependent portion. But look at the lack of honeycombing, not much distortion of the lung parenchyma. And here's a cellular NSIP after treatment. You see the contrast and how we can respond to steroid treatment. And here's an example of fibrotic NSIP that can be somewhat difficult to separate from UIP. But here's two images contrasting UIP versus NSIP. You see the peripheral distribution in both of the cases. You see more architectural distortion. You see how there is hypoinflation of the lungs in UIP, not much in SIP because there's not much retraction. And look at the fact that there is lack of honeycombing in a patient with NSIP. And again, it's a spectrum, and there may be some overlap. So just remember, in the ground glass opacities are mainly seen in patients with NSIP, but they can be seen in early UIP. Then you get the reticular pattern that can be seen in both, but then the cicatricial bronchiectasis, especially the honeycombing, is mainly seen in UIP. Remember, the DIP and also RBILD can give you these ground glass changes. I'm not going to get into the LIP, and I'll just show you some examples of LIP. Sometimes they can have a cystic appearance, and then it can be multiple like this, but look at the fact that it can mimic also a patient with either histiocytosis X or lymphangioliomyomatosis. The one that I want to talk about is RBILD, is the fact that it does have this acinar kind of disease where you see these fine ground glass opacities. I don't know how well it's projecting there, but in a heavy smoker, this is easily recognized. Those are fixed findings of ground glass opacities that are small, 5 to 8 millimeter in size, and sometimes they can be more geographic, like in this patient. But those can be reversible, and those are representing manifestation of inflammation in patients that are heavy smokers. Here's another patient with RBILD. And in contrast to DIP, where those can be much more geographic in appearance. COP, again, cryptogenic organism pneumonia, typically ground glass appearance, no areas of distortion, but the ones you recognize is when you have this reverse halo sign or the atoll sign that is highly specific of cryptogenic organizing pneumonia, and a patient with AIP. So I'm gonna stop here because I have only 15 minutes to talk on the next topic, which I think is very important. So let me very quickly move to the next topic. I have to apologize. Most of those talks were constructed for an hour to 90-minute talk, and it's hard to try to compress that into 25 minutes and leave out some of the important stuff. So to me, it's a brush from 3,000 feet trying to get into those topics, but at least trying to emphasize some of the basics, and I think that's the things that we need to remember. So if we go we're talking today about the solitary pulmonary nodule. So by definition, it's a sharply defined spherical or oval opacities, anywhere between 0.2 centimeters to 3 centimeters. 0.2 centimeters meaning that's typically when we start to find or recognize a nodule. 3 centimeters is the upper limit because beyond that we're talking about masses. And when we talk about mass, typically we're talking about neoplastic disease. We have to remember that ground glass opacities are part of the pulmonary nodules. So it's just a different appearance of a nodule, but it's not as solid as a typical nodule. We need to recognize that there are numerous benign and malignant causes, but what's driving us as radiologists is to be able to detect cancerous nodules at the manageable stage. And we know we're still doing a very poor job at doing that. And at the same time, because CAT scan is allowing us to see all those nodules, we have to refrain to intervene on benign lesions, so all those false positives that are coming into our light. So just for the novice, the typical pulmonary nodule, I'm not sure how well it's projecting here, but this is the typical nodules that we encounter. And I have to say that we see much more nodules than what is listed in the literature in our area because we're a high endemic area of histoplasmosis. So I would say probably half of our patients may have a pulmonary nodule of some sort. I know here we may have an endemic area of infectious disease, especially TB. So tuberculous granulomas can also manifest as a solitary pulmonary nodule. We know that, sorry, I went back. we know that CT can allow you for tissue characterization. Obviously, you can change your window and then try to analyze the content of the nodule. But most of the time, this is going to be like this. It's a soft tissue nodule that has no characteristic, and it becomes an indeterminate nodule. So the first reaction as a radiologist is prior studies. Before you do any investigation, do I have any prior studies to tell me that this is a nodule that has been stable for 2 years, or this is a newly appearing nodule? And a newly appearing nodule doesn't mean always malignant, but it still means something that you have to investigate. If the patient has a history of metastatic disease, then you have to make sure this is not a solitary pulmonary metastasis. But the first reaction is, before you go into a chase about all this fancy stuff, is get prior studies, prior chest x-rays, prior CAT scan if there is available. If you look at the literature, they said, okay, 150,000 per year on chest x-ray in the US. We know that it's much actually higher than that. In our area, we said that half of our cities do have at least one pulmonary nodule. But we need to also remember that the majority, in general, for patients that's 50 years old or more, the majority are going to be benign, and 2/3 of them, 70% or so, are going to be granulomas for whatever the cause of the pulmonary nodule. So the granulomas, there are multiple causes of infectious disease, whether it's bacterial, but most of the time fungal disease. So histo, TB, blasto, crypto, and so on, they all can give you a granuloma. And granuloma for us, it's easy to recognize when it's stable. It's easy to recognize when there's calcification. But beyond that, it's hard to determine actually it is a granuloma of a benign nature. There's some non-other infectious causes: Wegener's, sarcoidosis, hamartomas, which is a benign neoplasm, rheumatoid pulmonary nodule, silicosis, AVM, and so on. So the list is long. But again, we have to make sure that we're not dealing with the malignant cause. So the malignant cause is bronchogenic carcinoma, and that's going to be your number one cause of malignant disease. So, but you have some other causes of malignant causes of pulmonary nodule. Carcinoid, which is a relatively rare and different form of carcinoids. And then metastasis, obviously, that's one thing that can present as a solitary pulmonary nodule. The things that we have to consider, one is the size. So obviously, the larger the nodule, the more suspicious you need to become of the nodule. The appearance, so the more irregular or speculated, the more suspicious also. The growth, obviously, is important. So the faster the growth, and when I talk about faster, I'm talking about months, because the aggressive infectious disease can grow very fast. It can mimic neoplastic disease. So you have to be careful about that too. And our big motivation is the fact that we don't do well with lung cancer. Most of the lung cancers that we face are advanced cancers. But the fact that cancer has a lot of room in the lungs to grow before becoming symptomatic. So our role is to be able to detect those lung cancer at an early stage, for which we can make a difference, for which we can make an impact as far as either survival or actually cure rate. So we know that even now, with all the technology, the survival rate is still very dismal, talking about 12 to 15% in certain literature. But we know that if we detect cancer at the stage 1A or an early stage, we may have a 70% survival rate. There's always the argument about lead time bias and all that, but we know that some patients do very well and some patients can be cured if you detect cancers at an early stage. So our challenges is, one, as a radiologist, is to detect the nodule, so find the nodule. Once you find it, you need to characterize it. And then once you characterize it, now how can you prove the diagnosis? How can you make the diagnosis? We know that the chest X-ray is a very important tool. Almost every institution throughout the world, probably 50% of their radiology volume is based on chest X-rays. And there's a lot of findings on the chest X-ray. The new generations has tendency to jump to CTs, but just remember, the chest X-ray is still a very important tool, and we have to be able to rely on it, and hopefully not miss too many cancers. And we know that up to 90% of missed lung cancer I can see on retrospect. If you go back 2 years, 3 years before, where the lesion was there, but it was missed, and for multiple reasons. We know that in general, the smallest lesions that we can see on chest X-ray is 4 millimeter, in contrast to 1 to 2 millimeter on a CAT scan. And then we know in the literature that up to 80% of lesions that are 1 centimeter in size can be overlooked. So this is very humbling to know that. So I'm not going to get into the causes of why we miss, but obviously the lesion characteristic, the observer error, the technical consideration, and so on. It still remains the second most common cause of litigation in the US as far as a missed lung cancer on a chest X-ray. Used to be number one, but breast cancer took over, so there are more litigation on breast cancer. And I'm talking litigation of all medical fields, not just radiology. So very briefly, if you look at the tools that we have evolved from conventional radiography to digital radiography. Tomography went to multi-detector CT, and then we have, of course, PET-CT and MR, which has a minimal role in the detection and evaluation of solid pulmonary nodule. We know the advantage of digital radiography as far as post-processing, manipulation of the image, easy access, and being able to look at prior X-rays. And this is how we can manipulate an image on a digital image, and then you can put it in also reverse, and then you can see this nodule hidden behind the left heart. Dual energy, they talked about, our colleague before me talked about dual energy. Dual energy also 20 plus years ago played with chest X-rays, but it is something that never took over. It allowed us to basically remove the ribs and be able to see the lung parenchyma almost like tomography, but it's still a relatively expensive modality. It does have some increased radiation, so it never took off. The other thing that we're playing with and that still has some promises is tomosynthesis, and so you basically going back to the old concept of linear tomography, for which you can section through the lungs, and then you can see this patient with metastatic disease. But I think the one that is promising is this bone suppression technology. This is post-processing, and for which you can see lesions after you can see lesions better once you remove the rib, but you remove them in a digital format. So you're not re-exposing the patient, you're not doing linear tomography. So you can see this lesion in the right upper lobe much better than what you had it before when the ribs were overlapping the lesion. Do you see the lesion here? Where? Right upper lobe, left lower. Much more obvious now that you remove the ribs. This is an actual case that I have with this technology. How about here? Left upper lobe. Again, let me go back. And this is an actual case. This is actually the first day of my case, and I have to say that I read this X-ray and I missed the lesion. Applied this is post-processing, 2 seconds later, and here it is. How about here? I guess I don't have much time, but the other technology that we have is computer-aided detection, for which there is a region of interest that is highlighted by you. So just like a second reader that's going to highlight an area that the computer thinks is suspicious. The problem with this is they see too many false positives, but you as a radiologist has to determine what's true positive and what's a false positive. But it does allow you to enhance your ability to detect lesions. So this is a tough one. This is one of the studies I am conducting a clinical trial on computer-aided detection for the early detection of lung cancer. But this is a relatively hard lesion to detect. But the computer tomography, the CAD has outlined this here, but actually the lesion is here. And it's not until you do the CAT scan that you can see this early lung cancer here. But it did bring our attention to the lesion. This is an old study, and again, I want to go back to the importance of reading chest X-rays and looking at the hidden areas. And the most common cause of missed lung cancer and the most common region where cancer happens is in the upper lungs. So do you see where the cancer is? There's a 2.5 centimeter cancer here. So what you need to do, the first thing is looking at the hidden areas. So the hidden areas are behind the heart, the CP angles, outside of the chest, but also the apices. Look at the difference between this portion of the lung and this portion of the lung. See the lesion here now? This actually happened to be a physician that came with hemoptysis. Very hard to see on the lateral view because it's in the apices, but it's somewhere around here. But it's not until you do the CAT scan, you can see this is a relatively large lesion and how can be easily missed. And this poor patient actually did have metastasis, so it was a little bit too late, but you can see he's a smoker too. And this is to stress the importance of looking at those hidden areas. I just want to take a minute to talk about the appearance of the pulmonary nodules. So you may have calcification of the lesion, and they have different forms of calcification. You may have diffuse calcification, central calcification, ring-like, concentric. Those are all signs of benign disease and typically granulomas. You have the popcorn calcification that is due to a hamartoma. Those are relatively rare, but I think a better determinant of a hamartoma is the presence of fat, actually more than the popcorn calcification. Then you have the stippled calcification. That sometimes is hard because this can represent psammomatous calcification in a patient with adenocarcinoma, whether it's a primary or metastatic. And then you have the eccentric, and that's typically what happens is that there is a pre-existing granuloma and it's being engulfed by a cancer that's growing in the proximity of a granuloma, and it becomes part of the lesion. So those are somewhat suspicious. Now, if you don't have calcification, you can look at the contour of the lesion, and speculation typically means cancers. Speculation, lobulation, and lobulation also mean cancer. But then the well-defined, smooth, no calcification, this is the indeterminate nodule, and that's where we have a struggle, and this is where we need to look at evolution of the lesion. I looked at the fact that we can do some targeted imaging to look at calcification, but just remember granulomas and changing the windows can be easily detected when you see this pattern of calcification within the center of the lesion. Hamartoma, you can see the presence of fat, and you can see the calcification, whether the popcorn calcification or not. And this is, again, the fat is the most determining factor, not the size of a hamartoma. There's another hamartoma next to the hilum with fat and popcorn calcification. And this is a very large hamartoma, and this can be suspicious for a cancer, but obviously it does have the presence of fat and popcorn calcification. So it is a benign tumor, but it can slowly grow with time, and you leave it alone unless it causes some signs of compression. Now, I do have very few cases of cancers with microcalcification, and this is a patient with an adenocarcinoma with a psammomatous but very fine stippled calcification. And you can also look at the contour of the lesion. This is more suspicious of a cancer, not just the presence of calcification. So the point is that calcification doesn't mean always benign disease. Here's not a case where there's diffuse calcification, but in the right setting, this is going to be malignant, and this is a patient with osteosarcoma. So osteosarcomas, chondrosarcomas, synovial sarcomas, because they're bone-forming tumors, when they metastasize, whether in the lymph nodes or within the pulmonary nodules, they can be diffusely ossifying or forming cartilage. So in the right setting, calcification can also mean malignant disease. So this is ossification, if you want, of the pulmonary nodule. And you can see there is another deposit of metastatic calcification here and calcification within the lymph node. It doesn't mean always granulomas, another metastatic osteosarcoma. I showed you the case of pulmonary AVMs. I'm going to go very quickly, but I want to very briefly tell you that one thing that is important when we have pulmonary nodules that are indeterminate, one thing that we have tools now to allow us to evaluate the progression of the nodule. And it's very important not to look at the size by just diameter, but also to look at volume. And we can, isolate the nodule, we can look at the volume, we can identify, we can use computer tomography, but all those things are fancy methods just to allow us to see whether the lesion is growing or not. And it is important to look at growth, but we know that certain lesions will grow very slowly, some lesions will grow much faster. But typically, we need to evaluate the volume. We need to evaluate the lesion by volume, because the lesion can grow in an eccentric fashion. And we have to remember that usually we cannot intervene less than 5 millimeters, but we have tools that can look at temporal subtraction of the size of the nodule. So let me show you some few examples of, so we look at growth. You can tell this is in 2006, there is this small nodule here. We know 2004 wasn't existent. 2008 is growing, so this is a cancer until proven otherwise. So I'm not going to get into this. This is just a diagram to show you the evolution of the nodule and the timeline of a nodule and what we can see, what we cannot see. I have only 2 more minutes, if it's okay. But just to point out that 2/3 of the life of the cancer we're not going to see. And actually, the nodule is going to be invisible basically on chest X-rays and then probably to a lesser degree on a CAT scan. But it's not until it reaches a certain size in advanced life of the cancer then when the radiologist can play a role. So this has an impact about the screening and what we can do as far as screening and when we need to intervene, when we're not to intervene. But I just want to go very briefly about the fact that we have some other methods looking beside the characterization of the nodules as far as the content and the contour. We can look at the metabolism of the cancer, and of course, PET-CT can play a role, especially at the time when we cannot do biopsy. So a lesion that is more than 7 millimeters, I think we can play a role into trying to look at the activity of the cancer, of the nodule, determining whether it's a cancer or not. But more importantly, also we can look at the presence of activity within the lymph nodes. And of course, we have to look at other factors to allow us to determine what's the likelihood of being cancer. So the malignant probability, and the clinicians usually do that. So the radiologists will get them all the information as far as the size, the likelihood, and all that. But then they have to look at other conditions as far as the age, the smoking history, and so on. So something that the Fleischner came up, we had to use something very similar to the Fleischner Society because we're a high endemic area. But it does apply for patient that is 35-year-old and apply for incident nodule, no fever of unknown origin. And then we have to make sure that ground glass nodules may take a longer time to follow up. But you probably all have this, and this is available on the internet to looking at what are the criteria that you use as far as your follow-ups. So if a lesion more than 4 millimeters, usually you don't do anything about it. If a lesion that is on a high-risk patient that is 4 millimeters, you may do a 12-month and then stop if it doesn't evolve. But then if you can, and you stop if it doesn't grow. If a lesion between 4 to 6 millimeters, you do a 12-month follow-up on the low-risk patient, and usually stop if it doesn't change. If it's a high-risk patient, then you do more like a 2-year follow-up. So first 6 to 12 months, and then 24 months later, then you need to do a follow-up, and then of course you stop if it doesn't change. Now, as the lesion gets older, then you do shorter follow-ups, especially if it's a high-risk patient, you do much shorter follow-up. But the point is that after 8 millimeter, you have to be more aggressive and do shorter follow-up, especially in a high-risk patient. And then the high-risk patient, you may also elect at that size to do a biopsy and to do some PET scanning. So I'm not going to go into this here. I just want to show some examples. This is just the scenarios about what to do. But I just want to show you some example. Do you see the nodule here? Right upper lobe, right? Can't see it on the lateral, thick patient. Do you see it here? Well, here it is. So it's a skin lesion, right? So one thing is that we make sure that what shows on the chest as a pulmonary nodule is a true pulmonary nodule. Okay, 2008, you see the nodule here? Left upper lobe, I showed you this here. 2007 looked like it was bigger, but then 2005, the lesion wasn't there. This is too advanced. How about here? Cancer, no cancer. So it has irregular margins, right? Almost like a halo sign, suspicious, 1 centimeter. So actually, I brought this patient to do biopsy. I didn't have any prior studies. This is at the time of a biopsy. Ground glass lesion. Cancer should not regress like that. So this is most likely was an area of focal inflammation, even infection, within the confine of a secondary pulmonary nodule 7 weeks later. Here's another lesion that started as a ground glass opacity, but then within a few weeks, it's become very solid. And this is most likely to be a hemorrhageal infection. This is not going to be a cancer. How is it about this? Ground glass opacity. However, what you need to do with the ground glass opacity is you need to evolve. There can be adenomatous hyperplasia, there can be local inflammation, but remember, early bronchoalveolar carcinoma can present as a ground glass opacity. You worry about it when it starts to become solid. And this is how it evolves from a BAC into a solid adenocarcinoma. Here's another patient of a BAC evolving into a pulmonary nodule that is more solid. And when they're large, ground glass opacities like this, they have to be a bronchoalveolar carcinoma until proven otherwise. And this is another example of bronchoalveolar carcinoma. This one here, there's a granuloma on the right. And this is a lesion here. Spiculated, right? Irregular. Cancer, no cancer. 4 months later, disappeared, even though it was spiculated. This one here, cancer. So this one not only has the spiculated appearance, but patient has extensive emphysema, so we know this patient is a smoker. So this is a cancer antiprominal, except we couldn't do a biopsy on this patient because he has extensive emphysema, he's going to collapse his lung, he has poor PFTs, waited 4 months, cannot be a cancer. But what happened here, I want to point to this, the fact that here, what happened, the margins are spiculated, not because the lesion is spiculated, it's because those are the outline of the bullous disease surrounding the pulmonary nodule. 2 more cases, granuloma, even though the patient has breast cancer, mastectomy, but it has calcification. This is a granuloma, this is not metastatic disease. How about this one here? You do a high resolution. You do also the fact that the patient has lymph nodes. speculated margins, high resolution, speculated, little bit of emphysema. This is what? With adenopathy? Cancer, no cancer? Cancer. Histoplasmosis. This was resected. We assume it was cancer. There was no, but it turned out to be histoplasmosis. So aggressive fungal disease can present like that. Here's another patient with histoplasmosis, histoplasmoma presenting as a cancer, or mimicking cancer. But I just want to remind you, this is what you're going to see most. This typical nodule here. You see 2 years earlier, the lesion was there, but it was smaller. This has to be a cancer until proven otherwise. And you see adenopathy, and this is a cancer, even though it's small, it's speculated, squamous cell carcinoma. And here's another lesion, nodule, pulmonary emphysema, got bigger, speculated, this is a cancer. The tough one that we have is in the apices. When you have these areas of fibrosis, is this cancer, is not cancer, is it fibrosis? You follow it for many years, and then it's still turn out to be negative, it doesn't evolve. But you have to pay attention to those nodules. And this is an example of a patient that does have this nodule, however, presented a few years later with this, has brain metastasis, even though the lesion was less than 2 centimeters. And I always show these slides here, those 2 different patients, low resolution CT, large lesion, infection, cancer, no cancer? Cancer, right? You have the pack of cigarettes here. And you have the pack of cigarettes and the lighter. So you have the cause and the effect. And I'm going to stop here.
Thank you very much, Dr. Miziani, for this excellent review. Can you have a seat maybe with me here? You know, you did an extremely good job. You know, it's very important, as you mentioned at the beginning, especially whoever reading HRCT, that knowing the anatomy is the most important part. To understand the pathology, then you can read the CT for interstitial lung disease. If anybody have a question now, please. Yes, please. Can you have the microphones on the ladies' side, doctor's side? Just until she gets the microphone, how many of you, please, raise hands, do read HRCT? 1, 2, 3, 4, 5, 6, 7, 8, 9. Only 10 people. And the question is?
I want to ask about the technique when we suspect ILD. Should we start image the patient in prone position, or we do it supine, and if you see anything suspicious, then we...
So it depends. I'm sorry. So it depends whether you're looking for early interstitial lung disease or just regular interstitial lung disease to characterize it. I typically do it for patients. We do see a lot of legal cases, and we're looking for early asbestosis. And we want to make sure that what we see is early interstitial lung disease. That can be a manifestation of asbestosis. So that's the only time when I do both prone and supine. You remember, as you're doubling, you putting patient through 2 sets of studies, you're increasing the radiation. If you're just looking for characterizing of a non-interstitial lung disease, there is no reason to do that. If you're looking for airway disease, there's something where you need to do expiration and inspiration to see for air trapping and so on. But if you know that you're looking mainly for interstitial lung disease, let's say IPF, early IPF, or inflammatory disease, there is no reason to do both prone and supine.
My second question is, can we confidently diagnose a subtype of ILD with imaging alone, or we should go for lung biopsy?
So, as you know, that there have been a lot of studies trying to look at the accuracy of imaging in making the diagnosis of interstitial lung disease. And I have to say that with the latest classification, both the pathologists and the pulmonologists admit that actually imaging is much more sensitive in making the right diagnosis than those different methods. So I think we play an important role if we can recognize it. I still think that there's a lot of gray zones when there is overlap of disease or there is early disease. Are we dealing with early URP, or are we dealing with NSIP? And some people put some kind of test treatment where there is granulomas and they're going to try to treat the patient if they respond and so on. But we know the prognosis and evolution is quite different between NSIP and UIP. And UIP, no matter what you do, it's going to progress into a very rapid disease that the patient doesn't have quite of a good survival. But the point to your first question is that, yeah, as imagers, you can be able to tell whether this is a specific interstitial lung disease. So there are criteria for, let's say, UIP or IPF. You know, you have to find honeycombing. You have to find distortion of the lung parenchyma. But honeycombing is very important, and that's already, even though it's early, it's still important because usually you don't see it in other entities. Now, sometimes advanced fibrotic NSIP can do that, but usually you have made already the diagnosis of an SIP before that. So my point is that, yeah, you can be relatively specific about the diagnosis. And it's not all of them that end up having an open lung biopsy, but if the patient is going to become a candidate for a transplant, they are going to have an open lung biopsy to prove that before they can put them on a transplant list.
Yes, please, Dr. Zain.
Dr. Zain, excellent talk as usual. I'm wondering, for lung nodules, you go for a percutaneous biopsy. Why is it for interstitial lung disease, they go for open biopsy? Not
because you need much more tissue. That's the main point. You need to have enough tissue to be able to look at the whole pattern of interstitial disease, you know, whether it's the alveolar component. So you have to have enough material rather than open lung biopsy. But we used to do biopsies. Obviously, if you do a core biopsy of getting some tissue, you know, you will be able to get enough there. But most of the pathologists require enough tissue to make that diagnosis. And I don't know if there is some kind of immunotyping and things like that need to be done, for which an FNA will not give you enough tissue.
And probably, of course, if you do a lung core biopsy, it's going to make a big hole that you need to close.
Well, but at the same time, it's still less aggressive than open lung biopsy. You know, we're still in a good hand. You still the risk of pneumothoraces and hemorrhage is still much less than what you end up with an open lung biopsy. It's less discomfort than the patient, and of course, it's less costly to the patient.
Yeah.
As far as radiofrequency ablation for lung nodules,
I have to pass on that because we don't do it in our institution. So, but I know it is something that we can use as far as the treatment. Yes, for RF ablation is definitely an alternative. Yes.
A question there, please.
First of all, thank you for your very interesting presentation. I want please to ask about solitary lung nodules. The only way, from your opinion and your experience, is to follow up to if you are suspecting malignancy in this nodule?
So again, I mean, there are multiple steps, and I went very quickly through this. Actually, there is a cookbook, a diagram, what to do as the next step. So the first step is you have a pulmonary nodule, you see it on the chest X-ray typically, you have to get prior X-rays. If there are no prior X-rays, then you have to look at the size and look whether you have to raise a level of suspicion. You know, there are certain nodules on the chest X-ray that are going to be so dense that it's most likely to have microcalcification. They have this benign appearance. And then you have this vague, fluffy, poorly marginated lesion for which you don't know for sure. So if you don't have prior X-rays, I will do a CT scan. And you don't have to do a full CT scan. You can just do limited CT scan to characterize the nodule. And then from there, you're going to be looking for calcification, contour, surrounding, tissue and all that. If it still becomes indeterminate, then you have to see whether this patient is high risk or non-high risk. Be typically a 20-pack year patient that is smoker or non-smoker. And of course, if the patient has primary neoplasm somewhere, obviously you need to become suspicious and look for other nodules and all that. But if it's a high-risk patient, then depending on the size, I mentioned, below 4, usually you leave them alone. Between 4 and 6, if it's a high-risk patient, you follow them in 1 year. If it's a low-risk patient, for high-risk patient, you follow them for 2 years. But typically, lesions are stable in a span of 2 years. If a lesion is stable at 2 years, then you just forget about it. But typically, up to 1 centimeter in size, you do 3, 6, 12, 24 months. So you have the initial X-ray, and then you have 3 different follow-ups. And you double the time, assuming that it's always stable during that time. After 2 years, you can be confident that this is going to be a stable lesion and most likely a benign granuloma of some sort, or maybe even a non-calcified hamartoma and so on. Now, you have to also to make sure that ground-glass opacities or even nodules that due to bronchoalveolar carcinoma can slowly grow over time, and 2 years is not enough to follow them up. They're still relatively rare. The fact that you don't follow them that closely is okay because they have very indolent course. So even if you catch it 3-4 years later, it grew somehow, it's still usually self-limited, doesn't give you metastasis. So the prognosis is good. So you're relatively safe there. But typically it's the 2-year window. That's the way to do that. The other thing is that now with PET-CT, you can look at also as far as the activity of the nodule, and whether it's if it's a cancer, carcinoid, but especially remember that also patients that do have active tuberculoma or histoplasmoma can show some PET positive. But PET positive, but in a patient with the right history, smoking, emphysema, and then there is some activity in the 7mm nodule, you have to be suspicious of a cancer. Now, the last thing that I didn't mention that they do typically at Mayo Clinic, and I don't know if some people do that, is contrast enhancement. So some people think that if they look at the nodule, they enhance it. If it goes more than 20 Hounsfield unit, there's 80% chance of that being a cancer. We don't use it because we're high volume. We do a lot of CAT scans every day. We do around 100 CTs. And if I don't have the luxury to go and enhance every single nodule. But we have alternative, and I think PET-CT is a good alternative.
Please, I want to ask about first time to follow up. First time for either high risk or non-high risk patient. 6 months for both?
So it depends on the size of the lesion.
Yes, I know. But
so if it's let's assume it's a 1 centimeter lesion. So the high risk patient, I will do probably 6 months, 3 to 6 months, and make sure that I do follow up to 12 to 24 months. Low risk patient, I can stop after 1 year, and I can do just 1 year follow up or 6 to 12 months follow up. And usually, if it's stable, I just stop there.
Thank you.
What would be your approach if a patient has a known primary cancer, and in the CT, of course, frequently, almost every day, we encounter this dicta needle nodule that is only 4mm? What's your recommendation?
So if it's a newly appearing lesion, so this is not a coincidental lesion.
No, it's something that came for staging. She's a breast cancer patient.
So,
let's say, and,
so you have obviously those patients can have also metachronous metastasis. So they can have a single met. So that's they can also have synchronous other neoplasm. So the patients that have a primary cancer have most likely to have another primary cancer of a different cell type. But typically, if it's 4mm, I just watch it.
How frequent then?
So
she has a cancer.
This is then if it's
the
a
problem
cancer,
is the staging, and they want to do mastectomy or not for this patient.
No, I think usually what they do is that they give the patient they give the patient the benefit of the doubt, and they're not going to assume that is a metastasis, and they're going to treat aggressively the patient. So if there are more than one lesions, there are multiple lesions, even though they're 4mm, then you have to more think that those are multiple metastases. But the scenario you're talking can happen, but it's relatively rare. But usually they err on the side of being more conservative, meaning that they're going to treat that as just being an incidental granuloma, not considered as a metastasis. Oh. And this is the approach actually that mainly coming from the surgeons, or surgeons are more aggressive. We tell them we cannot tell if this is an early met or not. But you have to give the patient the benefit of the doubt, because you cannot leave that cancer not being treated as a non-metastatic cancer, and then on the thing that we don't have any proof on.
Yeah. Okay, at this we conclude the session. Thank you very much for your attendance.
Mm-hmm.